This episode of HIPcast is brought to you by Enterprise Social Record, the only closed-loop referral solution for social determinants of health needs built with health information expertise. ESR allows clients to assess, refer, report, and trend the SDOH needs of people in their care, report quality metrics like HEDIS and MIPS. ESR provides real-time CBO engagement in community-specific ecosystems with Z-coding and engagement in an anti-fraud framework. For more information, visit www.enterprisesr.com. And welcome to today's episode of HIPcast. It's great to see my co-host Shannon and our friend Elizabeth. And let's have fun with Elizabeth's last name, Delahoussaye. So her last name is a fun last name. And this is going to be a little bit of a rowdy podcast today because Elizabeth and I have known each other for far too long. And she was my work wife. My wife calls her my work wife. And we've been married, divorced, married again. It's very much a Jerry Springer relationship from the work wife perspective. But I'll read the bio here, and it should be a fun conversation. Obviously, Elizabeth's got an incredible amount of experience, and today's topic is going to be around privacy and what she does every day. So Elizabeth is Vice President and Chief Privacy Officer for Ciox. Elizabeth has served on the HIMA Board of Directors and was the Speaker of the House of Delegates in 2016. She also served as a representative for the Tennessee Health Information Management Association on the National House of Delegates, as well as president for THIMA from 2008 through 2010. And she was recently elected as president-elect in 2023 for Tennessee. Elizabeth has served on various committees at the national level with AHIMA as well, including co-chair of the AHIMA ROI Toolkit in 2013, the AHIMA Annual Program Committee in 2014 and 15, and AHIMA's Privacy and Security Council from 2017 to 2019. In 2013, she received the THIMA Distinguished Member Award for serving and volunteering over the years on both the state and national level. And in 2022, Elizabeth was named to Becker's Hospital Review's Women in Health IT to Watch and Women Power Players in Health IT. That had to be a very large trophy. Welcome, Elizabeth Delahoussaye, to HIPcast.
So just real quick, if we're going to have fun with the last name, I got to tell you guys the best story with my last name. And that was my husband and I went to a restaurant and there was a wait list. The little hostess was like, well, can we put your name on there? And so my husband said, sure. And so she's like, what's your last name? And so he spelled it all out. And that poor little hostess, she looked at that name and then she looked at him and she said, well, how do you say that? And as just straight face as possible, my husband looked at her and went, Smith. And that poor little hostess was like, I don't understand how you got Smith out of it.
Oh, that's funny.
I had to tell her, I was like, it's Delahoussaye, but you can just holler Elizabeth or John and one of us will show up. So
Elizabeth, so to just to set the audience straight, it's actually Elizabeth Delahoussaye. That's the straight up way to say it. That's correct, right, Elizabeth?
Yeah, you got it.
Okay, great. Well, thank you so much for joining. I'm going to level set for the listeners today. For anyone who does not know, maybe you could tell by the bio, but Elizabeth is one of the leading health information professional voices nationally for privacy around health information. Her and we have some really strong leaders in the state of Tennessee, as evidenced by Elizabeth's voice at a national level. The service she's done for the profession at our, with our organizations. However, additionally, the work she does on national level policy. So Elizabeth is more than just a pretty face and a funky name. So today, Elizabeth is going to talk a lot about what's going on today in release of information and in privacy. She'll talk some about covered entities and kind of some of the new challenges we're facing as an industry around health information, and how we're going to govern some of the things that we're facing now. But before we get started, Elizabeth, one of the things Seth and I have been doing that we have had so much fun with is we've been asking most of our guests to tell us their health information journey. We have heard some really amazing stories, and everyone is, even if there are some strands of similarity, there are some differences. So could you tell us your health information journey? How did you come to this profession?
Yeah, it's funny that you guys only have 30 minutes for this podcast, so I will try to not take the full 30 minutes on my journey. Because I have to tell you guys, I didn't start out in this world. I actually went to University of Tennessee and majored in business. And back up for a second. I started out in pre-law. Now, you're 18 years old and you think, oh my gosh, as you're sitting there starting your first, I'm really going to date myself, quarter, because that's what we were on. We were in quarters then. And I remember sitting there thinking to myself, oh my gosh, if I'm going to go to law school, you do know that that's 4 years of undergrad and 3 years of law school. It's 7 years. And, that's forever. And so that's when I switched over to business. And it's such a broad, area that when my husband and I got married and we moved to Louisiana, I decided to go back to school at University of Louisiana. And I was going through, again, the paper book. I'm so dating myself right now. And looking at all the different degrees they had. And one of them was, at that time, a medical record administrator. And I remember looking at that, and it had some privacy and, regulatory stuff under there. And I thought, well, this is really interesting. So I decided to go back to school and get that degree. Now, ironically, because business doesn't need sciences, and of course, our degree does need sciences, I had to literally add an additional year and a half. So let's go through all of this, right? I said I didn't want to go to law school because it was 7 years. As I'm sitting there studying one night, my husband walked by me and he said, so you didn't go to law school, why? And I was like, because it would have been a total of 7 years. And he goes, and you've been in college for how long? I'm like, 8. He's like, math, apparently, Starver cities. I'm like, yeah, I didn't think that one through. But I started out working for a company at that time called Reproductive, which was a release of information company. And I actually started out as their site supervisor at the University of Tennessee Medical Center. And then they had another position open up, which was a regional manager, and I got promoted for that. And then they had another role open up, which was a interim installation manager, which is where you start up accounts and things like that. And I went into that role. And then I decided to step away for a hot minute and figure out what this HIM world is, like what it's like to be an HIM director. So I did that at Blunt Memorial, and you guys will be able to figure out how much I enjoyed it when I make this statement. For 2 years, 9 months, and 6 days. So we all know how I enjoyed being an
HIM. Is that good, huh?
That's the sentence, huh? That was the sentence you took.
I have the utmost respect for HIM directors. I really do. I don't know how they do it. I got pregnant, and I was like, you know what? This is a great opportunity to exit out. So I left. And then after I had my son, I decided to be a stay-at-home mom for a little bit. That lasted for about 4 months because I am not a stay-at-home mom. And so Record-X had a position open back up. I know I'm like really not making myself sound really that great right now, am I? I can't do math. I'm not a great stay-at-home mom, and I'm not a good HIM director. So anyway, Record-X had a position open back up, and I ended up taking that and, going back to work for them. So as they've gone through mergers and acquisitions, as every organization has, we've been Record-X, Source Corp, IOD, and then we merged with HealthPort, and that's when we became Ciox. And I grew with the company as all of these mergers and acquisitions occurred. And then when we were IOD, I was one of their SVPs or senior vice presidents. And I really was, and it was operations. And it just wasn't something that I did a great job. I mean, I think my boss would say I did a great job, but he knew it wasn't my love. And so that's when we merged. He was like, you know what, you really should be in a chief privacy officer role, which is something I've always wanted to do. And so I was very fortunate, and this occurred about 7 years ago, that when that merger occurred, he put me in that particular position. And then it's, incredible to watch this. Like, when I walked into Ciox, we were Healthport and Ion. And then we had another division, which was ECS, which worked on the payer division, the payer contracts. And so it was so narrow as far as you're doing either release of information outside of the hospital, or you're doing release of information for the payers. And we look at the world I'm in now today, and, we have a life sciences division. We do a lot of pharmacology research. It's amazing. We're now a global organization. We have a division that's in Scotland. I mean, it blows my mind to think in 7 years that this is where we're at right now.
Yeah.
And there are times where I kind of push back and go, okay, and is the organization growing so fast? Am I able to catch up? And so far, I've been able to stay afloat and being able to understand all the upcoming regulations that are going on internationally. So that's my background. So now you guys know I was not a great mom. I don't do math.
I mean, it's a fun story. That's one thing that, like Shannon said, that I'm like, it's kind of it's been fun to sort of understand how people got to where they are, and the struggles, the journey, the fun that everybody goes through. And in your role as chief privacy officer for a major company that's now, international, what do you see as the biggest challenges with privacy and security, release of information, and just all of the things that you guys touch and that you've got expertise on?
Well, and it depends on where you're at when you ask me that question. Like here in the States, the biggest challenge that we have is consistency across regulations. And when I say that, meaning that everybody's like, well, HIPAA is your platform, which is correct. That is your platform that you've got to follow. But you've got so many different states that have so many varying regulations that you have to make sure that your staff is well educated on all of that. And I know that, we may talk about this a little bit, but, we've had a hot topic open up in the last 18 months around reproductive health. And that one is huge because states are coming out with their own specific regulations around when you can and cannot release. And then you've got, of course, OCR just issued, their notice of proposed rulemaking on what you should or should not release. So, and not all of this is not the perfect puzzle that meets together. And that's probably the biggest challenge of, you're talking about, crossing information across states, and it's not that easy. In the meantime, you got this other thing that's, hovering over your shoulder, which is called the 21st Century Cures Act, where they want you to move information across all these states. So it's very challenging when you're sitting there, trying to educate your staff as to, hey, no, you can release this, but you can't release that. But you can release that when there's this situation going on, but you can't release that when that situation's going on. It's not black and white.
Oh my goodness.
I know, it really is. And
so it's the conflicting, right?
It's so conflicting. It really is so conflicting. And I think that part of the problem is that what people outside of the healthcare industry is realizing, which the three of us already know on this call, is data. One, you have tons of data segmentation, right? Data stored all over the place. And secondly, it's integrated. So it's not like I can turn around and we'll pick on the reproductive health, and I can turn around and just go, well, I just won't release reproductive health. Well, reproductive health is such an integrated part of your medical record. And so it's not as easy as me saying, I'm going to remove anything that's reproductive health, because it's all incorporated in there. It's scattered throughout. And then the other thing is to think about when we sit there and have conversations with a lot of our providers, people automatically assume under reproductive health, we're talking about females' reproductive health.
Right.
But yes, we're talking about males too, because it's not a gender specific regulation.
I thought that I was not included in this. So that's news to me.
What's so funny about this is that I tested my theory. One of our providers in New Jersey, where you have to give explicit consent to release your reproductive health, created a authorization form. So I handed it to John and I said, I want you to fill this out. So there's those little boxes, right? Like HIV, STDs, and reproductive health. So he fills out the whole entire form. And he didn't mark reproductive health. And I said, why didn't you mark that box? He goes, well, it doesn't apply to me.
Really?
It actually does.
I'd have been in the same boat. Yeah. I mean, I guess that's a great call out of education that needs to occur.
Listen, Seth, I have to say, I know women are powerful and strong, but we still need the other 50% for it to be a whole reproductive health.
It's been a while since I took A&P.
Right?
Sorry.
It's like I was like, I don't think I did this by myself. But yeah, I mean, it's like we talked about, we were talking about prostate health. Like, John was in a study several years ago for LSU because his dad had prostate cancer, and they asked for all of his children to, male children to participate in the study. So there's prostate health. What if he had a vasectomy? Anything within that area, it's all incorporated, and that's all considered reproductive health. And it's like I tell people, I'm like, when you go into the doctor's office and you get a history and physical, when they ask you both under the history and they perform the physical, they're doing the head to toe. So reproductive health is just as ingrained as your cardiology health, your what's the word I'm trying to think? Respiratory health. How to think about what that word was. Your respiratory health. All of those things are incorporated and ingrained in there. And so that's one of the things I think a lot of legislators are now realizing. Like, it's not the flip of a switch to turn this information on or off.
Surprising to think that there's a disconnect between legislation and reality.
I know. It's shocking, isn't it?
I don't know if we just heard the national gasp.
I'll give OCR some credit, because when they came out with the notice of proposed rulemaking, they actually, I think they kind of recognized, like, okay, this isn't easy to segregate out. And so their recommendation is, all right, since you can't segregate that data out, then what we'll do is that if you're in a state where a procedure such as an abortion is legal and somebody's requesting your medical records that is law enforcement, they have to provide an attestation stating that they're not going to utilize this for criminal court proceedings. That makes perfect sense, right? Because it's legal in that state. If they're asking for the information where that procedure is performed is illegal, then they have a right to that information because they're investigating a crime that may have occurred. It makes perfect sense. But here's the challenge. So let's just say you reside in a state where an abortion is considered legal up to 12 weeks. And then after 12 weeks, it's considered illegal. So now you've got an individual who's having to pull up a medical record and go, okay, when was this person? How far along was the pregnancy?
The rule changes depending on the day of the patient. That's wild.
Or better yet, what if it's legal in their state and it's illegal in another state, and that law enforcement agency is asking for information from their state?
Yeah.
Now they're going to know, well, was it illegal in your state or was it legal in your state? So it's not just I have to know what's going on in my respective state. I got to know what's going on in my neighboring states as well. So that is a huge challenge when you look at that. So I think that OCR had the right idea of recognizing you can't pull the specific information out, but not recognizing the challenges of all these different states that are coming out with these varying regulations that are around it. And then on top of that, so let's just say the notice of proposed rulemaking passes as is. Well, your state laws, if they're more stringent, you still have to follow them. So let's go back to New Jersey, the one I was giving you guys an example for earlier. It says you have to have an explicit consent on the authorization allowed. So you still have to have that authorization. So let's go to John's scenario. John didn't mark the reproductive health. So if he sent that into that facility, the facility has a couple of options. They say, okay, well, John, I can't release anything to you because you didn't mark reproductive health, and I can't sit there and redact everything out. So, you either have to mark the box, which is kind of backing that individual into a corner, right? You got to mark the box.
Absolutely.
Or you say, I can't release it because you didn't mark the box. So now is that some form of information blocking? Or your third option is you get a clinician down, because none of us are clinicians, right? And you get a clinician down to come down and literally start redacting everything that's
Oh my
reproductive health
goodness.
related.
Wow, what a chat.
And
What
you
a
can
struggle.
imagine how labor intensive that is.
Wow.
And so, even again, I think OCR, it'll have some platform just like HIPAA does, but it's not going to supersede some of these more stringent states and some of their regulations.
So is this just a case by case basis for your company then? Is this just a daily decision making process? Do you have a decision tree like you did for assigning DRGs back in the day? How do you, I mean, seriously, how do you keep
We have
up?
a dartboard and we just start throwing darts.
Here.
Yeah.
That is not true. Ciox does not stand behind that statement.
I promise. No, so we do. We have, each state has now we have state SOPs already, but we've had to provide some labor intensive, again, education around the reproductive health for those respective states. Right now, the state line crossing piece is not a big issue. But again, I can see that because most of the states that have like certain regulations around releasing information and having explicit consent, they're kind of clustered together. But when the notice of proposed rule comes out, I can see some states modifying some of the regulations, and then there's going to be some challenges with that.
Goodness.
So that's one of the challenges that we have in today's world. Would you let me?
Huge. I have to think about, with the reproductive health. This sounds as conflicting as SAMHSA and HIPAA.
It does.
It sounds almost identical to what weighs the most or what supersedes what, and it's never the same answer. Well, I mean, I guess occasionally it's the same answer because you only have a certain number of combinations, but it's still, how do you know, how are you protecting your organization from information blocking or from exposing a person's information that shouldn't have been exposed? And it's just a constant, and everyone thinks the health information management person's job is not that difficult.
Yeah.
And I'm telling you, and that's what's so funny. That's one of the reasons why I stepped out of the HIM director role, because most HIM directors were taking on this privacy officer role. And I was like, this is way too much. So, for those HIM directors that that have dual roles right now, my heart goes out to you, because I have a staff of 10 and we're trying to keep up with this. I cannot imagine how you're doing this, even if it's just, again, your state, there's still so much going on at a state level. I don't know how you're keeping up with it right now. So yeah, it's very, very challenging. And that's just, and keep in mind, we're talking about HIPAA and 21st Century Cures Act. We've got other proposed rules over there that are coming out.
Sure.
Or have come out, and these aren't covering covered entities or business associates. It's kind of like the FTC's got their proposed rule coming that's gone out, opened up for comments, and theirs are more focused on those that are not covered by HIPAA and those parties that are involved with healthcare. And that one's interesting too, because when I read that particular rule, I think to myself, okay, how do you stop and start that? Meaning, if you want to manage apps and making sure that if they have a breach, they're reporting them appropriately, which app are you managing? And the example I've used, and I think I've used this example with you before, but it's like, for example, I have, of course, everybody has their Apple Health Watch, right? Or app. And so that app, that app is connected to my Lose It app, which is also connected to my heart rate app, which is also connected to, when I'm trying to monitor my blood glucose app. So, if one has a breach and it trickles through to all, which one gets managed? And I think that's where's one start.
Scares me a bit.
Stop. Exactly. And it kind of going back to reproductive health, it's like, a lot of individuals have, monitoring period app, menopause apps, all of those.
Yeah.
And those are incorporated together. So I think that's one of the things with FTCs. It's like, okay, where's the clear line in that one? And is there a clear line? And the answer may be it may not be a clear line right now.
Yeah, and I think we're getting data from so many places. There's definitely not a clear line. And I also think at some point you have to determine what's going to be covered under HIPAA and what isn't, right? So even if I'm using all these third-party apps for my own personal health, that's my own personal health. That's probably not going to be tied to HIPAA. But if I'm using patient generated health data and I'm pushing it into an EMR, maybe that's the answer. When it gets to the EMR, it becomes, medical record data, and then it has to be protected, right? But at the same time, we're talking
just to
about
interrupt you quick, Shannon. Here's the question I would ask though: is when does it get pushed into the EMR? And the example I would give is about 4 years ago. I went on a trip, and while I was out, we still don't know what happened, but I literally just passed out. I mean, we don't know if I was dehydrated or whatever, but I had my Apple Watch on. So when I went to my doctor, I was plenty. I had
For those
lots of
listeners,
water. Let me
Shannon
clarify
just
my
made a
hydration level. It was lots of water.
yeah,
So when I got back, I went to my doctor and I was like, okay, here's my Apple Watch. It's monitoring obviously my heart rate. And we're looking at it and I'm like, okay, this is the point in which I passed out. And he reviewed it and he probably incorporated that data into his medical decision, but he never asked me for that data. He just looked at my phone and was monitoring.
Oh, interesting. Yeah.
So
Clinical decisions made off that information.
there was a decision made off that information.
Yeah. But then he probably, I would make an assumption there that it's documented somewhere in his note, right? Related to you, which, I'm not going to ask you to reveal your personal data to tell us that. But I will say, we're thinking about, we're talking a lot about patient generated health data and apps and things like that, and how HIPAA applies to those, and are those covered entities? Do we need a BAA? Things like that. But I wanted to bring a thought to discussion here about a similar but different group of players that are entering the healthcare space, community-based organizations to help close the gaps for health-related social needs, social determinants of health.
Yep.
So we're asking now, these are entities that already exist. They're in communities. They're already, providing support services for their community, but those are being originated from somewhere outside of the healthcare space. Yeah. Now we're bringing that into the healthcare space, and that support request is coming from the healthcare sector, which is great. And it's wonderful. In fact, that's why I have a job right now, because that's what I'm doing. But the point is that we're asking these community-based organizations to manage the support for those social needs for people who are considered patients. So do they become a non-patient once you shift that over to the CBO, community-based organization, CBO, to close? Are they now not a patient? Well, I have to say they're still a patient, because we're asking those community-based organizations to report back information, which is going to become part of that person's medical record and will be forever in their history, right? As long as their digital record exists. So if you, and I have to think, Elizabeth, that HIPAA is hard for all of us to understand, and we've been doing this for years. How can you expect a community-based organization that maybe has consistently changing staff and stakeholders, depending on the level of need or just finding new jobs, different things like that? How can we expect them to understand HIPAA from a covered entity or even a BAA perspective? BAAs are hard. A business associate agreement is a hard thing to understand. So are we moving this into a place where that becomes unprotected data? Whether by regulation or just by default?
Yeah, I mean, gosh, Shannon, that's a really great question and a really hard one to answer, because you're right. When does it become patient and not patient? And then here's the other thing with that community. So let's look at this 30 years ago when we talked about social determinants of health. It was very limited to what's going on in your household. And I know everybody, do you feel safe? Are you, that kind of thing. But I think everybody's realized it's more than what's happening in my household. And I think a good example,
Mm-hmm.
and I've used this before, is Flint, Michigan, right? When all of that water
Absolutely.
issue occurred, that wasn't what was, I mean, granted,
Absolutely.
the water issue was happening in that individual's household, but the community across, everybody was
That's right.
experiencing issues. So if they had strong social determinants of health in Flint, Michigan, would it have been recognized earlier that there is an issue with the water, right? But it wasn't. And I think that social determinants of health and community-based organizations, you're right, it's something that's coming into the ecosystem, the healthcare ecosystem. And I think everybody's kind of pushing back a little bit, going, I don't know what to do with you. Yeah, and
Mm-hmm.
I mean that to be very transparent and honest. They're like,
Absolutely.
do you go as a business associate? Well, you're not a business associate because, you're not
Right.
necessarily getting information from other covered entities. You're getting it from the community. But yet you're trying to pull information together to give it to covered entities so they can make some appropriate decisions. And so it's a
Yeah.
really
Let me throw
tough.
one more caveat. Let me throw one more caveat at you, Elizabeth. So we are bringing those community-based organizations in as part of the value-based proposition. So because of treatment, payment, and operations, does that change your thoughts?
Maybe you should have gone back to law school.
I know it, right?
I
Did
threw
you
you
get
a zinger.
online and Google what's the hardest questions I can ask Elizabeth and see what she can do?
No, I don't think we have answers. I just think we're really bringing this in as part of value-based proposition. And I
Yeah.
understand that, right now TPO is really part of fee for service, but it's also part of, in terms of regulatory space and requirements, it's also part of value-based care. And if we're really bringing in those CBOs as part of value-based proposition, then I think we're expecting them to be healthcare players,
Well, I
in
do
a
think
sense.
I do think that even if you don't get under the definition of a covered entity, I think it is expected that you're going to maintain a certain level of privacy. And we've been fortunate because most CBOs are being started by incredible people like yourself who understand the importance of that privacy. Now, that's today. 3 years, 2 years down the road, are we going to have those same individuals or different individuals with the same integrity? And I'm fearful that that's not the case. So do I think we need to have something around it soon? I do. Are you providing direct care to the patients? In my mind, and this is Elizabeth Delahoussaye's opinion, I think that you're providing a service to these patients. And so with that being said, I think that there needs to be some sort of parameters such as security and privacy parameters put in place that has some sort of oversight to make sure that you have that patient's privacy up front, in the forefront of your mind, and making sure you're protecting
So
them.
in our space, we have HIPAA, right? And we love
Right.
HIPAA, and we love to correct people that get the acronym spelled
Oh, yeah.
incorrectly. That's one of
Oh,
our
yeah.
favorite things to do as HI professionals. But so we have that. What needs to occur to HIPAA to update it to serve the providers, to serve the covered entities, and to protect the information that's in non-covered entity worlds?
Yeah, and I don't think adding an addendum to HIPAA is necessarily going to be your answer. To make modifications to HIPAA is literally an act of Congress. Let's just be realistic. I mean, it's a very challenging thing to do.
Yeah.
This is one of those times where the pun actually works. But I do think, yeah, exactly. But I think that there needs to be some additional privacy regulations that recognizes the CBOs and social determinant of health and what they're going to do to ensure privacy. And again, I think maybe the FTC tried to step into the world a little bit as far as breach reporting, but that's if you have a breach. What are you going to do to protect that patient's privacy? I mean, if you
Yeah,
think about it, Shannon,
absolutely.
a CBO has more. I mean, let's be very realistic about it. Like, it's one thing if you got into my doctor's record and it's like, oh, okay, great. You got my blood pressure, you got my height, oh, for the love of Pete, now you got my weight, those kind of things. But when you get into social determinants of health, you're going to be like, okay,
They know
she's been
everything.
everything. She's been married for
Financial
30
data,
years. Yeah.
children.
Yes.
Absolutely. Yes.
Yes.
Scary
all
stuff. Scary
some
stuff.
very scary stuff, right? And so
Mhm.
that's the reason why it's like, and I don't know if you want to have this, so let me just put that out there, but it's like, okay, should it be at the same level or higher than HIPAA, and what information
Mm-hmm.
is protected? And,
Yeah,
are you
and
ready for those regulations?
yeah, and one final thought for me, Seth, before we close out. One final thought about it is that if we, as a healthcare industry, are recognizing and then bringing in social determinant and health related social needs into that whole person care kind of trifecta, there's some onus on us as healthcare professionals to protect by encryption and security and all of the kind of ways that we do it. We can't really protect it once it's opened within those CBO organizations, but when we're sending information to them, the appropriate encryptions and protections in place, because we can't expect the CBOs to protect the way that we do, because they don't know our rules in our healthcare rules and industry rules, and what regulates us. But what we send to them and how we send it should, by all means, meet the requirements around HIPAA. Seth, I got nothing else about it today. I mean, we could continue to ask questions, but that's all I have is more questions.
This sounds like a 12 to 13 day conversation that could occur, and we would never solve it all. So it's been fascinating to realize how complicated this really is. Just simple release of information all the way up to privacy and security. And then when you add in all these covered entities and non-covered entities, Elizabeth, I do not envy you and what you have to deal with every day, but I do want to thank you for joining us on HIPcast today. This has been a fascinating conversation. I'm sure you welcome our audience to connect with you on LinkedIn and to reach out if they have any further questions. Good. And I do want to thank our sponsor of this episode again today, who is Enterprise Social Record, the only closed loop referral solution for social determinants of health needs built with health information expertise. ESR allows clients to assess, refer, report, and trend the SDOH needs of people in their care. Report quality metrics like HEDIS and MIPS. ESR provides real-time CBO engagement in community-specific ecosystems with Z-coding and engagement in an anti-fraud framework. For more information, visit www.enterprisesr.com.